Good morning. My name is Charles Guardia. I'm a sleep medicine physician and clinical assistant professor of neurology at the Robert Larner College of Medicine at the University of Vermont. And we're going to be talking today about EEG engineering principles, artifact, and the neuroanatomy of sleep. But before we get started, a few housekeeping issues. I want to remind the audience that questions can be asked of me using the Q&A panel at any time during this presentation. And this webinar is being recorded and will be posted on the AASM website in about 1 or 2 weeks after today. I have no relevant conflicts of interest that pertains to this talk today. So let's get started. So when we talk about EEG, what are we really talking about at a neuronal level that occurs in the brain itself? So the EEG is something that records electrical activity of the cerebral cortex. This activity is small. It's measured in microvolts, and it takes about 6 square centimeters of cerebral cortex in order to generate a signal that we can record. But we also have to amplify that signal about 1,000,000-fold for us to be able to see this on our computer screen. So we're really talking about postsynaptic potentials when we talk about what we record. These potentials occur on the order of about 50 to 200 milliseconds, so they're ideal for recording given their duration as well as the field that they generate. So at the postsynaptic membrane, a neurotransmitter induces a change in transmembrane potential, and this results in 2 different types of postsynaptic potentials. We have excitatory postsynaptic potentials. It's where we get a local reduction in transmembrane potential, or a depolarization, and this typically occurs at the dendrite of the neuron. And we have inhibitory postsynaptic potentials, or a local hyperpolarization in transmembrane potential, and this is typically located in the cell body of the neuron itself. So if excitation exceeds inhibition, we get repetitive action potentials, and this is what results in seizures. And I want you all to think about the EEG really as a snapshot of both time and space at any particular moment and what the brain is doing. So really it is just the temporal and spatial summation of all the extracellular voltage changes that we're recording. So it's this combination of excitatory and inhibitory postsynaptic potentials that induce local currents that flow in and around the neuron itself and generate an electrical field. So really we're just creating a dipole. That's all that really is that we're recording from. So positive ions that move into the cell make the brain surface more negatively charged. So we think of this as both a source and a sink. And the explanations are there on your screen. So the source is the current from the inside or outside extracellular space, and the sink is the converse, which is current from the outside to the inside part of the cell. So really, these pyramidal neurons are oriented in plane, and it's really electrical fields that generate this kind of time and space summation, temporal spatial summation that we get and we're able to record. Like I said, this signal needs to be amplified significantly in order for us to see this, because we're talking about very small potentials. So when we really talk about this, it's the brain itself is something that acts as the electrical generator of bioelectric potentials, in addition to the volume conductor itself. So the concept of volume conduction is really just a 3-dimensional angle. So we're looking at the surface area of a sphere. So you can kind of think of this dipole. It's kind of like a coin. So that one layer of the coin is negatively charged and the other layer of the coin is positively charged. And the electrodes on the scalp themselves are kind of like spotlights. So we're recording this information. It's what the spotlight sees, really. So the cortical pyramidal neurons are just creating this moment in time where we see changes in electrical potential. So this is a single pyramidal neuron and the field that it generates. So what we're looking at here is a vertically oriented cell, and there are 2 points in time. So we have, say, point A and point B, and point C and point D along different areas. So we have the top portion is more negatively charged, and the bottom portion is more positively charged. And this is going to illustrate the point that points A and B, the potential difference between the two of them is 500 microvolts, so 200 plus 300. Points C and D are along the same line. There's no potential difference between the two that you're recording from. So the fact that the pair of electrodes at which the largest potential is recorded is not always closest to the area of the brain that generates that potential. So the brain is a lot more convoluted than just, say, a simple coin-like structure. So what we're really seeing is different gyri. So this is a crown of a gyrus that we're looking at. So the same type of thing. A spotlight is being shown upon that dipole layer. So this spotlight sees more negative charge, and this one sees more positive charge when we look at this. And two-dimensionally, you can kind of think of this as a coin being tossed into a pond, and where the coin strikes the water is the point of maximal electronegativity, and it creates a ripple effect that you're looking at. Okay, so really what we're doing is recording the potential difference between 2 points, and we have conventions for this. So up is negative and down is positive. And the axiom is that if input 1 becomes relatively negative with respect to input 2, there will be an upward or negative deflection. So this is a full complement of electrodes. So this is, sometimes I look at this when I wear my neurologist hat, and then I look at a different complement of electrodes when I wear my sleep medicine physician hat. So I link my montage a little bit differently when I look at sleep studies than what the American Academy of Sleep Medicine recommends if I'm looking for something different. So I tend to link the left-sided electrodes, so F3, C3, and O1 together rather than linking F3 to the referential one on the opposite side. So once again, getting back to this concept of time and space, or temporal and spatial summation. So what that spotlight sees, so if you link F3 to the contralateral ear, there's a lot of actual ground that is being shown upon. Whereas if you link the electrodes closer to one another, you're going to resolve the signal a bit better. Okay. So there are certainly rhythmic generators of what we see on the EEG, and this is really the oscillation between excitatory and inhibitory postsynaptic potentials. And this is inherently due to a few different things. Intrinsic membrane properties themselves, neuronal synaptic potentials, and then thalamocortical connections themselves. So thalamic neurons will fire and excite cortical neurons, and these will then recurrently inhibit themselves via inhibitory interneurons. And it's really the rhythmic firing of the thalamus, which causes that rhythmic firing in the cortex, that we get these extracellular changes in voltage. So about 100 milliseconds is something that translates to about a 10 hertz, or what we typically see as a normal posterior dominant alpha rhythm in the EEG. And then we also want to think about the eye as a dipole as well. It has a charge. The cornea is relatively positive compared to the retina, which is a little more electronegative. So you can think about this in the fact that wherever the eyes will look will become more electro positive. So when we normally close our eyes go up, the so-called Bell's phenomenon. So the frontal polar electrodes and frontal electrodes become more electropositive. So that's why we get those wonderful eye blink artifacts. So I'll give you a moment to take this in and orient yourself. So I want you to draw your attention to E1 to M2, and there's a couple of different explanations for this. So the patient is clearly awake, and we get these wonderful eye blink artifacts over here on E2. So the one possible explanation is that you have a bad E1, or in this case, this patient actually has a glass eye, so their false eye does not create that dipole where you get those wonderful eye blink artifacts. Great. All right, so let's talk a little bit about normal sleep. So N1 is about 2 to 5% of our total sleep. If we see a little bit more than that, we think of sleep as being fragmented, and some of our patients with obstructive sleep apnea will have an increased amount of N1. N2 represents about 45 to 50% normal sleep. N3 is anywhere between 8 and 15%, but that actual percentage does decline with age. And REM is pretty well preserved across the lifespan and represents about a quarter of our total sleep time. So as we can see here, slow wave sleep is something that wanes some with age. So in N1, we get that wonderful slow rolling eye movements. This are greater than 500 milliseconds, and we get this dropout of our normal posterior dominant rhythm. We get this theta activity, and there has to be more than 50% of the epoch for us to call it N1. We also get vertex sharp waves, and these are less than a half a second duration, and they're maximal over the central leads. And this is exactly that. We see a transition from normal kind of waking alpha into N1, and that's theta with those slow rolling eye movements. And that's just another example of N1. So N2, and the hallmark are spindles and K complexes. The spindles are usually between 12 and 14 hertz, but can range anywhere from 11 to 16 hertz. They're about a greater than or equal half a second in duration, are also maximal centrally. And the spindles themselves are generated by the reticular nucleus of the thalamus. It's the only nucleus of the thalamus that talks to itself. And K complexes are negative sharp waves followed by a positive component, and the duration is greater than or equal to half a second. And it's actually an auditory evoked response was initially described. They would have patients who were asleep and they would knock, and they would see this evoked response. So that's where it gets its name. This is a good example of a K complex right here. And our sleep spindles in N2. Right. So I want you to draw your attention to the arrows here. And that's a 30-second window. This is a 10-second window. It's the same phenomenon that we see. These look like little sailboats going by. These are something called posts. So this normally happens during stage 2 sleep, and they're these triangular waves of positive polarity. They're a normal finding, and they're often mistaken for something that is epileptiform in nature. So N3 is comprised of delta, so that's a half to 2 hertz. It has an amplitude criteria, that being greater than or equal to 75 microvolts, and it's comprised of greater than 1/5 of the epoch, 20%. And there's a good example of delta waves in N3 sleep. Okay, so REM is comprised of conjugate and rapid, so that's less than 500 milliseconds compared to the, in contradistinction to the slow rolling eye movements we talked about in N1. And these are more horizontal and vertical. And we get this low voltage asynchronous pattern on our EEG. And REM is really the neurophysiologic equivalent of wakefulness. we get these sawtooth waves, and they're in the 2 to 6 hertz range. And the 2 to 10 hertz activity of our hippocampi in the CA1 division and medial entorhinal cortex is really what drives that activity. So there's a couple of different types of REM that we see in sleep studies. There's phasic REM, where we get bursts of neuronal activity in our pons and raphe nuclei, and we get alternating constriction and dilation of the pupils. There's also non-phasic REM. So our deep tendon reflexes are abolished, so we get this inhibition of the alpha motor neurons in the spinal cord when that occurs. So it's a good example of our rapid eye movements, very sharp deflections, and then our sawtooth waves. Okay, so let's talk a little bit about how we as a species sustain wakefulness. So it's really the rostral reticular formation that's necessary for sustaining wakefulness. And this is something that originates in the pontomedullary junction and projects widely through the midbrain, hypothalamus, thalamus, and cortex. So lesions, so a stroke, mass lesion, like a tumor here, will produce profound somnolence and coma. So the ascending reticular activating system is, really something that we shouldn't think of as kind of a monolithic structure that comes from, kind of pontomedullary area and then has these widespread projections up into the cortex. Rather, it's a system of different neuronal networks that interact with one another that help us to sustain wakefulness. And this works through a number of different waypoints and nuclei throughout the central nervous system in order to accomplish this. It was called the reticular system because when neuroanatomists looked at it underneath the microscope, initially the pattern was that of a lattice-like structure, so that's why it got that name reticular. But it's not a monolithic structure. It's a complex network of structures that are involved in helping us to sustain wakefulness. So we have a number of different neurochemical systems that help promote wakefulness. Acetylcholine is one of them and very abundant in the basal forebrain. And we get a lot of fast EEG frequencies from our basal forebrain. It is also abundant in the pons, so the lateral dorsal tegmental nuclei and pedunculopontine tegmental nucleus. And these project through the thalamus, basal forebrain, and lateral hypothalamus. The lateral dorsal tegmental nuclei promote wakefulness by releasing acetylcholine into the thalamus itself. So norepinephrine is very abundant in the ventral medulla, as well as the locus ceruleus. And these particular neurons fire during wakefulness and are key in keeping us on task and paying attention to things. Histamine is also key in attention and is abundant in the tubomammillary nucleus. And this is exactly that slide again, where we have that complex interaction of different neuronal networks that help us to sustain wakefulness that begins kind of in the pontomedullary junction as widespread projections all the way through the cortex. And we talked about the locus ceruleus, which is the source of norepinephrine, the tubomammillary nucleus, the source of histamine, the basal forebrain, as well as the pontine nuclei that are involved in release of acetylcholine. So serotonin is abundant in the dorsal raphe nucleus. So how, in fact, serotonin helps us sustain wakefulness isn't necessarily well understood. But 5-HT1A, 1B, 2, and 3 will all promote wakefulness. So any of the medications that inhibit these receptors will obviously are something that will make us sedate. So dopamine is abundant in the ventral tegmental area as well as the substantia nigra. And the extracellular levels of dopamine are highest during wakefulness. And we encounter folks who are sleepy and have dopaminergic dysfunction, certainly in the clinic. So individuals with Parkinson's disease will often become sleepy. And individuals who utilize typical antipsychotics that block dopamine, so things like haloperidol and chlorpromazine, will also engender somnolence. Orexin is synthesized in the lateral and posterior hypothalamus, and those neurons, in fact, project to the locus coeruleus as well as the tubermammillary nucleus, and this helps us to sustain wakefulness. So we can think of folks who have problems with making CSF orexin. So these individuals are most commonly what we see as narcoleptics. So it's the intrusion of sleep into wakefulness. So individuals have a problem with sustaining wakefulness who are narcoleptic. We also see low CSF orexin levels in folks with Parkinson's disease, traumatic brain injury, and multiple system atrophy of the Parkinsonian and cerebellar type. So there's our orexin system with its widespread projections. Okay, so let's talk a little bit about the ventrolateral preoptic nucleus. So this is what helps us maintain sleep. So it's really the median preoptic area that initiates sleep, and this set of neurons fire at the onset of non-REM. But it's the vilpo itself that helps us maintain sleep. This is located just above the optic chiasm. And there's two different populations of neurons in the ventrolateral preoptic nucleus. There's a core set of neurons, and these project to the tubermammillary nucleus, as well as an extended, and those project to the dorsal raphe as well as the locus coeruleus. And these contain inhibitory neurotransmitters, so ghrelin and GABA. This is exactly that, so just located above the optic chiasm and has widespread projections. So we can kind of think of this as a flip-flop switch when we talk about our ventrolateral preoptic area and the arousal system. So it's a mutually inhibitory switch. It's like a seesaw. So here we have our kind of homeostatic sleep drive, that circadian hypnotic signal. We've all experienced this when we're on call very early in the morning. We have a very strong drive to go to sleep, and this drives the ventrolateral preoptic, core and extended, and promotes sleep. And then we'll send inhibitory signals to orexin, as well as the tubermammillary nucleus, locus coeruleus, and raphe, which are all those wake-promoting systems. And then the converse is that circadian alerting signal, and that activates the wake-promoting systems and inhibits the ventrolateral preoptic area. And this is a very quick process. So if you want to think about the fact that if it took us 30 to 45 minutes to wake up, we probably wouldn't make it very far as a species if that saber-toothed tiger came into the cave and tried to eat us. We have to wake up very quickly in order to extract ourselves from a potentially life-threatening situation. So this is something that the transition from wakefulness to sleep and vice versa occurs very quickly. It's like flipping a light switch off or on. So we do have certain chemicals that do make us sleepy, so-called somnogens. Adenosine is one in particular. So as we're awake, our brain has metabolic activity, and it accumulates adenosine. When we become tired, adenosine is no longer phosphorylated, and those adenosine levels rise, and to some extent are governed by astrocytes, which are the support cells of the nervous system. And most of us take caffeine, which is an adenosine antagonist, and this will help with sleepiness, and that's why caffeine is alerting. So we'll talk a little bit about the neurophysiology of REM. So we alluded to this earlier when we talked about the different nuclei that are involved in production of acetylcholine, so lateral dorsal tegmentum and pedunculopontine tegmental nuclei. You can see here, so the green is REM on and the pink is REM off. So here, and this drives down into the motor neurons themselves and leads to atonia. So why are we paralyzed during REM? So it's these group of neurons, the lateral dorsal tegmentum, pedunculopontine tegmental neurons, that project to the ventral medial medulla and in turn send inhibitory messages to the motor neurons in the spinal cord themselves, the alpha motor neurons. And this leads to muscle paralysis, obviously, except for the diaphragm in our eyes. And it's a combination of not only inhibition, which is mediated by GABA and glycine, but a withdrawal of excitation, so norepinephrine, serotonin. So this is why norepinephrine, serotonin, reuptake inhibitors will unmask motoric activity in REM behavioral disorder. So the sublateral dorsal nucleus, we get loss of neurons in this particular nucleus in individuals with REM behavioral disorder itself. Okay, so we obviously dream during REM, so how does this occur? So these group of neurons, the lateral dorsal, tegmental, and pedunculopontine nuclei, project to the thalamus itself up through the lateral geniculate nucleus, and it's really the main source of acetylcholine to the thalamus, and this is what drives those pontogeniculate occipital waves and are key to the complex visual imagery that we experience during dream mentation. All right, so we got through the neuroanatomy part of the talk. We'll talk a little bit about EEG artifacts and normal variants. All right. So I want to draw your attention to the arrows here. The fact that it is time locked with our EKG. So this is nothing more than EKG artifact. So we see this commonly in our patients, especially if they're leaning on their left side. And this is something that should be recognized, especially because it's time locked to the EKG itself. All right. So, patient's not awake here. Draw your attention to the arrows here. This is a phenomenon that is not time locked to the EKG, but we looked at this before. These are posts, so the positive occipital sharp transients of sleep. They're electropositive. They can be mono or biphasic and can occur in long runs, typically seen during stage 1 and stage 2, N1 and 2 sleep, like sailboats passing by. Okay. And here the arrows are pointing to just problem with impedance. It's a bad electrode. Right. So the patient's awake. It's a 30-second window. And I'll tell you that they are an adult, but they have a 7 Hz posterior dominant rhythm. So that's slow for an adult. And this is a bad O2. So we can fix this a couple of different ways. We can re-reference, or we can actually fix the electrode itself. So this here is excessive beta activity, often due to medication effect. So barbiturates and benzodiazepines will produce this. So this here, we'll look at it first on a 30-second window, and then on a 10-second window. So this is generalized spike and wave. So this is a patient with idiopathic generalized epilepsy. So this phenomenon also is a 10-second window. Go back, that's a 30-second window. So this is different from what we just looked at. This is something called hypnagogic hypersynchrony. It's a high voltage diffuse theta activity, usually 4 to 5 Hertz, and lasts a few seconds, but there's no epileptiform discharge buried in this here. So this is fairly common in children, starts in and around about age 1 and typically wanes by age 5 or 6. And this is a normal phenomenon at sleep onset in a child. So this is not an abnormal pattern. So I'll call your attention to the red arrow here. So we'll look at this on a 30-second window, patient's awake, and then we'll look at it on a 10-second window, and it's much more noticeable on a 10-second window. So this is a patient with bilateral occipital spikes, epileptiform discharges. This is somebody with focal epilepsy. We see this here at 01 as well as 02. And this is a 30-second window. What we see here on the left side. And this is a 10-second window. It's much more pronounced. So this is something called benign epilepsy of childhood with central mid-temporal spikes or BECs. So these focal epileptiform discharges are present over the really left central region. We don't have temporal electrodes here on this montage, but this is a benign epilepsy of childhood, and these children usually have nocturnal seizures, and this is something that should be recognized on sleep studies as an abnormal pattern. And those are my references, and I would be happy to entertain any questions that you may have. Okay, someone asked me to go back and point to the epileptiform discharges. I'd be happy to do so. Great. So right here, you see focal epileptiform discharges at 01 and 02. So occipital spikes. And this was the particular individual with the benign epilepsy of childhood with central mid-temporal spikes or BECs. So right here, so left central, so C3. Good. I hope that answers your question. All right. Well, if there are no other questions, I appreciate talking today, and I hope you learned a bit more about EEG and artifact recognition and certain abnormal patterns. It was a pleasure talking today. Thank you.